morning, respected teachers, my colleagues, and dear students. Department of Palliative Medicine is going to present today's CCR. Palliative care is a very specialized care which is given to the patients suffering with life-threatening illnesses. Our main goal is to improve the quality of life of the patients. Palliative care in India was recognized as postgraduate course in palliative medicine in 2010. Our hospital was the first private medical college in North India to start MD palliative medicine. Department of Palliative Medicine was established in our hospital in 2019 and we got approval for 3 MD palliative medicine seats from NMC in 2021. Currently we have 3 residents with us who are pursuing this course. We provide palliative care services to the patients suffering from various chronic and life-limiting illnesses like cancer patients, patients having chronic obstructive pulmonary disease, neurodegenerative diseases, end-stage renal diseases, congestive heart failure, elderly patients, and end-stage liver disease, to name a few. We work together with the Department of Medical Oncology, Surgical Oncology, and Radiation Oncology for the better patient care. We are admitting patients in the IPDs. This is the pic showing the same. On an average, we have 250 to 300 patients OPD per month, and on an average, we are admitting around 30 patients in IPDs in our wards per month. Seminar, journal club, multidisciplinary tumor board, multi-specialty faculty lecture is a regular feature of our teaching schedule. We are using morphine and transdermal patches like fentanyl patches and buprenorphine patches for the pain relief of our patients. In addition to this, for the patients who are not getting benefit from the oral medications, we are doing procedures also. Lymphopress, we have a machine lymphopress which we use in the management of the lymphedema in the patients who are operated cases of CA breast, and for pain relief we have TENS machine also, and we are doing other regular pain relief procedures. We are also doing image-guided interventions and blocks. Neurolytic blocks are especially helpful in the patients in the advanced cancer when they are refractory to the oral medications. We are also doing end-of-life care, which is a special care which is given to the patients when they are approaching end of life. This is a kind of comfort care, and we follow a policy which is being made by our institution. We follow the guidelines in doing the same. Apart from that, we want to help our patients with dance and music therapy also, which is an important and integral part of palliative care. We work with NGO like Sanjeevani for psychosocial help to the patient. For the patients who are not able to take admissions in the hospital and want to stay at home for the rest of their life, we are taking home care services by Pareek. Our center is European Society of Medical Oncology, designated center of integrated oncology and palliative care for the period 22 to 24. Apart from this, we are conducting regular workshops. We are running certified course in palliative care and caregiver course for the last 2 years. Our faculty has attended many national and international conferences. We are also participating in community awareness because palliative care is less known in the community. And we also participate in many social events. We have 3 international and 5 national publications. Recently, I got an opportunity to visit GCRI Ahmedabad as an external examiner. So these are few pics of the activities being conducted by the department. So we had celebrated World Hospice and Palliative Care Day on 2nd October and it got a good coverage in media. So these are few glimpses of the events being conducted by our department. Besides academic activity, we are also participating in various social and cultural events. On 15th of July, our department, in association with Medical Oncology and Critical Care, is organizing a CME on Let's Talk About Death. I would like to invite everyone to attend the same. Our future plan is to establish the state-of-the-art hospice center. Hospice care centers are the one where the patients during terminal stages of illnesses, when there are no treatment options left, it is neither a hospital nor a house. It is like a place where skilled medical care is given to the patients in home-like setting. That is, it is home away from home. So now I would like to invite Anukriti Pareek to start the presentation. Thank you.
Of Palliative Medicine, and today we are presenting a case of a 65-year-old male with painful tonsillar enlargement. So this case was referred to us from the Department of Radiation Oncology. I therefore first request Dr. Sanjana to come and open the case.
Good morning, respected seniors and my colleagues. I will be presenting the case of a 65-year-old male who came to us with the complaints of swelling on left side of neck associated with pain and swallowing since 3 to 4 months. The patient is apparently well 4 months back when he developed painful swelling in the left subauricular region, which was insidious in onset. The swelling was initially the size of a pea and progressed to the size of a lemon, and the pain associated with the swelling was gradually progressive and radiating to the left ear. It was a continuous pain with no diurnal variation, causing insomnia to the patient, and it was a sharp and tingling kind of pain. The pain was aggravated on swallowing and not relieved by oral pain medications. The intensity of pain on numerical rating score was 5 to 6, which is moderate pain. Rhinophagia was to solids and started around 10 days after the swelling and was gradually progressive. It was not associated with regurgitation of food. The patient visited an outside hospital and was advised biopsy, after which the patient came to Mahatma Gandhi Hospital, Department of Radiation Oncology. There was a history of chronic VD smoking, 45 years, and the patient used to have alcohol once a week. The past illness, family history and treatment history were markedly unremarkable. To summarize at this point, a 65-year male, chronic smoker and occasional alcoholic drinker with gradually progressive painful swallowing and left neck swelling since 3 to 4 months. At this point, I would like to ask if anybody has any idea about the differential diagnosis in this case. For the complaints of a rhinophagia, we can have infective or inflammatory causes like oral candidiasis, viral esophagitis, caustic ingestion, pharyngitis, and aphthous ulcers. For benign causes, there can be possibility of hiatal hernia or esophageal spasm or stricture. And in malignant causes, carcinoma of head and neck, example oropharynx or oral cavity. For complaint of cervical swelling, the infective and inflammatory causes could be cervical adenitis secondary to upper respiratory tract infection like tonsillitis or Epstein-Barr virus, tuberculosis and sarcoidosis. Benign causes could include lipoma, fibroma, neuroma and salivary gland mass. Malignant causes could be carcinoma of head and neck with secondaries to neck, hematolymphoid malignancies and extramedullary plasmacytoma. The general examination of patient was relatively unremarkable except for lymphadenopathy noted at level 2, which will be further explained. There was a single visible spherical mass in the left upper jugular region below the angle of mandible. It did not move with dilatation, it was non-pulsating and no engorged vein seen. There was no discoloration of skin over the swelling. The temperature of the skin was not raised. It was non-fluctuant and it was a single hard fixed tender mass 3 by 3 centimeters with ill-defined margins at left level 2 and the skin over the mass was non-adherent. This is a diagrammatic representation of various neck node levels and their respective lymphatic drainage from head and neck regions. As our case has cervical swelling at level 2, we can see that it gets lymphatic drainage from oropharyngeal region, mainly tonsil and base of tongue and parotid. For oral cavity, the oral hygiene was seen to be poor with adequate mouth opening of 4 centimeters. Lips and gums and bilateral buccal mucosa and hard and soft palate were normal and so was the uvuline floor of mouth. There was no deviation of tongue or ankyloglossia seen. There was ulceration with irregular margins seen over the left tonsil with white slough over the floor extending to left lateral base of tongue. There was ulceroproliferative growth with everted edges over the left tonsil measuring 4 by 3 centimeters and involving left lateral border of base of tongue, which is not crossing midline. There was marked induration of the edge and base of ulcer fixed to the underlying tonsillar bed. To again summarize at this point, 65-year-old chronic smoker and occasional alcohol drinker with gradually progressive painful swallowing in left neck since 3 to 4 months, with an ulcerative lesion with irregular margins over the left tonsil measuring 4 by 3 centimeters, with white slough over the floor, everted edges and marked induration fixed to underlying tonsillar bed. It was continuous over left lateral border or base of tongue and not crossing midline, and with a single hard fixed left level 2 node of approximately 3 by 3 centimeters. The patient was referred for radiological examination and contrast enhanced CT neck was suggestive of ill-defined heterogeneously enhancing mass of size approximately 39 by 35 mm involving left tonsillar fossa.
His left ear had a problem with it. His left ear had a problem with it.
The pain was radiating to the left ear.
But there was something inside it. Did you examine the ear? You didn't get it. ENT people are very angry. Common situation that when you see an obvious lesion, you overlook the other. Right? So ear examination.
The mass was extending anteriorly into the left side base of tongue, involving the left lateral border of oropharynx with an enlarged lymph node at left level 2, measuring 40 by 32 mm. Oral punch biopsy was requested and sent to the Department of Oncopathology for evaluation. And for discussing the pathological aspect, I would like to call upon Dr. Aditya Mundra from the Department of Oncopathology.
A very good morning to all. I'm Dr. Aditya Mundra and I'll be discussing the pathological aspects of this particular case. We received fragmented soft tissue pieces altogether amounting to 1 centimeter in the greatest dimension. Microscopic examination, we saw tumor cell nests, islands, and they were also forming syncytial pattern. And there were presence of keratin poles in the center of the tumor cell nest. The individual tumor cell nests were polygonal in shape and they were showing individual cell keratinization. Also, there were presence of intercellular bridges. There were presence of keratin poles at the center of tumor cell nests. The tumor cells were polygonal in shape and they were exhibiting moderate amount of pleomorphism and anisonucleosis. There was presence of individual cell keratinization, and also there were presence of intercellular bridges. All these above mentioned features were being exhibited in around 60 to 65% of tumor cell population, and a diagnosis of moderately differentiated squamous cell carcinoma was given. Now I request Dr. Sanjana to talk about the further workup of the case.
The rest of the hematological and metastatic workup of the patient, including a chest X-ray, were unremarkable. And the final diagnosis of the patient was made. A 65-year-old male patient, chronic smoker, with carcinoma of the oropharynx, clinically staged as T3N2A M0, when moderately differentiated squamous cell carcinoma. The case was then discussed in a multidisciplinary tumor board, and the patient was planned for concurrent chemoradiation and pain management. After multidisciplinary tumor board discussion, as per standard treatment protocols, the radiation treatment plan was given as 70 gray in 35 fractions, 5 fractions per week over a period of 7 weeks using image-guided radiation technique. Here are the contouring guidelines of the above the said patient. And for concurrent chemotherapy, patient was referred to Department of Medical Oncology. And to discuss the details of that, I would like to call upon Dr. Joydeep Singh Basant.
So, good morning everyone. I'm Dr. Joydeep Singh Basant, the second year DM resident in the Department of Medical Oncology. So as Dr. Sanjana had already mentioned, that the patient had been discussed in a multidisciplinary tumor board. So the final diagnosis, as also already mentioned, was CLF tonsil oropharynx, moderately differentiated squamous cell carcinoma. And it was a stage 4A, locally advanced disease. So the plan was concurrent chemoradiation. So taking into consideration the performance status of the patient, he was ECOG performance status 0, which means that the patient could do his normal day-to-day activities along with any exertional work without any hesitancy, without any issues. So considering the body surface area, we had planned for giving cisplatin 40 mg square, which was 60 mg, 6 doses, weekly doses. And cisplatin is one of the most commonly used chemotherapies given along with radiation, but it still does not come without its side effects or toxicities. It's a highly emetogenic chemotherapy. It does cause myelosuppression. Even it does it is a very emetogenic regime. So the patient was given adequate hydration and iodine along with administration. And before each cycle of chemotherapy, we had to get a hemogram done along with the serum creatinine and a bilirubin and RPS. So this is the medical oncology part. Now I'd like to call upon Dr. Anukriti Pareek to take this CCR forward. Thank you.
So first we have to understand that palliative care starts as early as diagnosis is made. So this patient was referred to us with complaints of pain on left side of neck and pain on swallowing from past 3 to 4 months. And he was referred to us on day 3 of the radiation therapy. So for the history of pain, patient had pain in the left side of neck from 3 to 4 months, which was insidious in onset and gradually progressive. It was severe continuous pain with no diurnal variations. It was aggravating on ingestion of food. The intensity on the numerical rating score was 5 to 6, and it was also radiating to the left ear. It was sharp and tingling kind of pain, and because of the pain, the patient was unable to sleep. In palliative medicine, we also take account of the psychosocial history of the patient, because we believe that pain, we deal in pain as a total pain, which is physical, emotional, spiritual and social. So sometimes the psychosocial history can be of relevance in managing the pain. Patient and his son were the only 2 members in the family, and patient had lost his wife few years back to cancer, so that instilled in him a fear of death, having seen her suffering, and he felt hopeless. The son is 37-year-old, unmarried and doesn't have a fixed job. The relationship between the father and son is not very strong. Now the other systems in the patient's body are working fine, so the patient does feel hungry but is unable to eat due to the pain, and that causes a lot of distress to him. Patient also feels trouble due to the continuous pain and the daily hospital visits for the treatment. This is a patient assessment sheet. This is the pro forma that we have in the Department of Palliative Medicine, where we take into account the pain, all the components of pain, and the pain is rated on scales like numerical rating scale and Wong-Baker scale. Also assess the other symptoms that are associated. On the Edmonton symptom assessment scale, we have 10 points. They're not eligible, but we keep in account the pain, the tiredness, the anxiety, depression associated, the difficulty in sleep, and they are graded from 0 to 10, where 0 means no complaint, or 10 means the maximum possible complaint the patient can experience. Also, we do the general physical examination and systemic examination, and also keep account of the previous treatment being given. So this was the pro forma of the patient on one of the days of follow-up. So numerical rating scale is the scale that we have used for the assessment of pain in this patient, where 0 means no pain and 10 is the worst imaginable pain that the patient can experience. From 1 to 3, its severity is mild, 4 to 6 being moderate, and 7 to 9 being severe. The blood investigations have to be taken in account whenever we are prescribing any analgesic medication. So it was markedly unremarkable. So to summarize at this point, a 65-year-old male, known case of oropharynx left side, with swelling on left side of neck from 3 to 4 months, pain in swallowing from 3 to 4 months, on chemotherapy post 1 cycle and radiation post 3 fractions. On the local examination, there was a subauricular region mass of 4 by 3 centimeters with ulceroproliferative growth on base of tongue. So now, coming to the management, we had to manage the pain of the patient. We had to ensure oral hygiene in this case. Also take in account the nutritional rehabilitation and give psychosocial support. So on the first visit when the patient came to us, which was post 3 fractions of radiation, the pain score on NRS numerical rating scale was 5 to 6. We had followed the World Health Organization step ladder for cancer pain management. This is the WHO analgesic ladder. So it has 3 steps. In the first step, the drugs used are non-opioids and other adjuvants like antiemetics, antidepressants, anticonvulsants, antibiotics if required. If the pain is not dealt with on the first step, we have to move to the second step of the ladder, which includes weaker opioids like tramadol, codeine, and along with it, the drugs from the first step, that is non-opioids and adjuvants, are followed. And if there is no relief on this step, we have to move to stronger opioids, that is morphine or fentanyl, and any other available stronger opioid. So for the symptom management, in this case at this point, we first suggested oral care with salt and soda mouthwash and started the patient on NSAIDs, ibuprofen and paracetamol 12 hourly, along with adjuvants, that is gabapentin, in a dose of 100 milligrams at night. And also advised oral topical lignocaine solution 4 times in a day, 15 to 20 minutes before meals, so it's easier for him to swallow. We requested the patient to come for daily follow-up, and he was indicated ongoing radiation daily. So from day 2 to day 5, we could see that on the numerical rating scale, the pain score was 2 to 3, which was mild on the ongoing medication. From day 6 to 7 onwards, the patient again started complaining of pain, and the numerical rating scale score was 5 to 6, which was the previous score that is come with. So the 7 days follow-up, post-radiation 8 fractions, we have the patient with a numerical rating scale score of 5 to 6. Now, as the patient's pain has persisted and increased despite the ongoing analgesic medication and dose adjustments being done in between, we advise patient the medications according to the second step of the World Health Organization analgesic ladder. Now the patient was shifted on tramadol, which is a weak opioid, and along with that we had continued all the other analgesic medications that were being given to him. And the patient was again requested for continuous follow-up. So day 8 to day 10, the score was 3 to 4 between mild and moderate. But day 11 onwards, patient came with severe pain again, the score being 7 to 8. At this point, we had to do re-evaluation and reassessment of the patient. We checked for local examination and we observed that the buccal mucosa revealed erythema and ulceration on the left side of the buccal cavity. So this basically is oral mucositis, which is mainly chemo or radiation-induced oral mucositis. It is a very common unavoidable complication of chemotherapy and radiation therapy. Usually occurs after 6 to 7 cycles of radiotherapy and after chemotherapy, depending on the dose being given. It lasts for up to 4 to 8 weeks from the last chemo or radiation cycle. So now, On the basis of assessment, we could see that the patient had mucositis grade 3. He could not swallow food, he had difficulty in swallowing food. So step 3 of WHO step ladder was now practiced on day 11 onwards. Patient pain score on numerical rating scale was 7 to 8 on weak opioids and adjuvant drugs. Now patient was shifted to stronger opioids. So we started the patient on oral morphine 5 milligram every 4 hourly, and then the dose was escalated to 10 milligrams 4 hourly according to the requirement of the patient. Even with the ongoing morphine medication, patient had a numerical rating scale score of 5 to 6. So as we know that morphine is a narcotic drug, comes under the NDPS Act. So the storage and dispensing of this drug has to be well documented. This is a narcotic drug prescription from our institute, and whenever we are prescribing a narcotic drug, morphine, fentanyl or any other strong opioid, we have to provide the patient along with our prescription with this narcotic prescription. Both the leaflets are provided and kept stored in the pharmacy, and without these we cannot dispense morphine, along with the national identity card of the patient. On the 14th day follow-up, which was after 2 cycles of chemotherapy and 15 fractions of radiation being given, the pain score of patient was 5 to 6 on the numerical rating scale score, and the patient at this point was on oral morphine 10 milligram being given 4 hourly and on all other adjuvant drugs along with. The challenge that came here was that now the patient was becoming incompliant to the treatment. The patient's pain was persistent despite all the oral analgesic treatment being given. The frequency of morphine is 4 hourly. It was becoming very difficult for the patient to swallow, so he was not willing to take that dose on that frequency. So now we had to think what else we could do for the patient. So patient had then to be planned for spinopalatine ganglion block.
Okay, what would you do now? All of you are very, learned clinicians. This is a patient who has severe pain. पेशेंट का कंसर्न तो ये है कि मैं दर्द लेके आया था, मेरे को 15 दिन हो गए ट्रीटमेंट लेते हुए और कुछ फर्क नहीं पड़ा, मैं तो बंद कर दूँ. So how would you help him? Any resident? Can you suggest something? We did let the cat out of the bag very quickly. We showed you the next slide, but I think most of you were sleeping, so no damage done. So tell me, any resident, any specialty, what options do we have now? He is already on the top rung of the WHO pain ladder. अभी और क्या कर सकते हैं इसके लिए? Anybody? कुछ भी, like this is not an uncommon situation. I know that you don't treat malignancies, but yes, please. Excellent. So one suggestion to the audience is that you could think of a nerve block. Very good. Anything else?
Euthanasia?
Yeah. So this man needs to be flogged publicly. This is a patient who has a curable malignancy. He has a 60% chance of being cured. You know what is euthanasia? So never even think of that. Okay? Don't even think of that at this particular point of time. And euthanasia in our country is murder. You don't want to be charged with this or no. So, sir, any comments? Dr. Sudhir, our Vice Chancellor, is a renowned anesthetist. What would you do, sir?
Before that, the patient is unable to take orally, right?
Yes.
His nutrition also is not adequate. So put in a trial tube and then feed him through that and give the medication through that. The patient probably will agree to take better medication.
So actually, Ryan's tube insertion was advised, but the patient was very adamant to not go for it. We really counseled him very well for that.
Okay, carry on, please. As an extreme measure, yes, but after giving him local anesthetic sips, he was able to maintain his blood pressure. Maybe 75% of the calories he was able to take, and he was resistant for a nasogastric feeding tube, so he was absolutely flatly refusing for minor surgical procedure. Go ahead.
So patient pain persisted on oral analgesic treatment, and then patient was planned for a sphenopalatine ganglion block. The procedure was well explained to the patient and informed consent was taken. We planned 4 sittings of transnasal sphenopalatine ganglion block initially for continuous sittings and then followed by sittings as required. So before we proceed further, I would request Dr. Prabjot Kaur ma'am, Associate Professor from the Department of Anatomy, to kindly talk about the sphenopalatine ganglion.
Good morning, everyone. This sphenopalatine ganglion, it is located below and lateral to the orbit in the pterygopalatine fossa, and this fossa is an enclosed space. It's a small pyramidal space which is bounded anteriorly by the tuberosity of the maxilla and posteriorly by the pterygoid process of the sphenoid. So the postganglionic branches from this sphenopalatine ganglion, they reach the oral and the nasal cavity through the sphenopalatine and the greater and lesser palatine foramina. The preganglionic fibers to the sphenopalatine ganglion, they arise from superior salivatory and inferior lacrimatory nucleus located in the pons, and the preganglionic fibers, they travel through greater superficial petrosal nerve and relay in the sphenopalatine ganglion. The postganglionic fibers, they reach to the nasal cavity through the sphenopalatine foramen, to the oral cavity through the greater and lesser palatine foramina. Now, these greater and lesser palatine foramina, they are carrying, the palatine nerves, they are carrying the postganglionic fibers, but they are actually the sensory branches of the maxillary nerve. So the pain sensations from the oral cavity and from the buccal mucosa, they will be traveling along these nerves, and they pass through the ganglion without relay, and these might be the branches which are responsible for carrying the pain sensations in this patient. To elaborate further on the sphenopalatine ganglion block, I invite Dr. Nipun Lamba, Associate Professor from the Department of Palliative Medicine. Thank you.
Good morning, everyone. I am Dr. Nipun Lamba, Associate Professor in the Department of Palliative Medicine. So what is sphenopalatine ganglion block? What is sphenopalatine ganglion block? Does anybody know? As we know that we have just seen sphenopalatine ganglion in sphenopalatine fossa, we are going to block it. So how? Who described it? Sphenopalatine ganglion block was first described by Sudha for scleral neuralgia. He has done this sphenopalatine ganglion in way back 1908. And this ganglion is used in various pain syndromes. It has numerous implications you can't even think of. But currently the most important implication is in head and neck and facial pains, including cancer pain. So sphenopalatine ganglion, which is also known as Meckel's ganglion, it is located in pterygopalatine fossa. We discussed its triangular shaped structure, and it is just below the maxillary nerve as this nerve crosses the fossa. The flow of blood to nasal mucosa, particularly to the venous plexus of Conque, is regulated by it, and it is also maintaining the temperature of air in the nose. This ganglion has sympathetic, parasympathetic, sensory components and numerous branches: orbital, nasopalatine, greater palatine, tonsillar, branches to the salient ganglion, carotid plexus, facial nerve, superior cervical ganglions. Anatomy is discussed by Prabjot ma'am. So this is a fluoroscopic image of sphenopalatine ganglion. You can see here that this bony structure, clivus, and this is sella turcica where pituitary gland rests. Below it, sphenoid sinus, and just right here is a triangular shaped structure which is sphenopalatine fossa, where the sphenopalatine ganglion is located. So what are the indications of sphenopalatine ganglion block? Can anybody tell? Anybody from neurology? No? From internal medicine? So you can send us patients later on. Thank you. Head and neck cancer pain, facial pains. sphenopalatine neuralgia, in idiopathic trigeminal neuralgia, along with Gaussian ganglion block. Sometimes even Gaussian ganglion RF is not sufficient to treat trigeminal neuralgia. Patient still has pain. In that case, we have to do sphenopalatine radiofrequency ablation too. In varieties of headaches, cluster headache, migraines, post-dural puncture headaches, post-herpetic neuralgias, atypical facial neuralgias. There are a lot of other indications as well which are not related to head and neck, but we can have them for later part. So there are various techniques for sphenopalatine ganglion block. There is a transnasal technique, there is transoral technique, there is infrazygomatic approach also. So this is an image how the procedure is done. So as you can see, this is the medial nasal turbinate and a cotton tip applicator is inserted, and here its tip rests on the sphenopalatine ganglion. So pharmacological agents we are using 2% lidocaine, 0.5% bupivacaine for it. There is a cotton tipped applicator which we are commonly using, and there is also specified devices like Spinocat transnasal device which is available these days. So what we do, sphenopalatine ganglion block is done by a transnasal approach in which we apply local anesthetic to the mucosal membrane overlying the ganglion. The patient is asked to lie supine and pillow is kept under the chest so that the neck is protracted. Appropriate monitoring was attached. Patient's pulse, BP are recorded, heart rate is monitored, saturation is recorded. The patient is supine like, and the nose is tilted upwards like we are inserting a nasogastric tube. We are using 2% lidocaine. Before it, what we do, we use 0.5 ml lidocaine and we instill it into the nasal cavity and ask patient to sniff it back like. So what it happens, it lubricates the nasal mucosa as well as it anesthetizes the pathway for the insertion of cotton tipped applicator. Then 1 ml, then we insert cotton tipped applicator through the superior border of middle turbinate and it rests on mucosa overlying the ganglion. Then we instill the local anesthetic 0.5 to 1 ml in frequent increments over that cotton tipped applicator through the channel so that the drug goes over it. And that applicator is kept there for 20 minutes. The patient after this procedure is requested to rest for 20 to 30 minutes and then discharge after proper monitoring. So this is a video. I'll show how we are doing it. So as you can see, on this cotton tipped applicator, we are instilling local anesthetic. So the patient was saying the same thing, and he told us that he got relief of about 80%. The patient told us the same thing, that he got about 80% of pain relief after instilling this doing this transnasal sphenopalatine block for about 4 sittings. We had planned that if needed more, it will be done after alternate settings or as patient's pain eventually returns. This is not a permanent procedure. There are permanent procedures. We can do chemical neurolysis of sphenopalatine ganglion through infrazygomatic approach. We can do radiofrequency ablation, but this patient was poor. He was not able to afford a costly treatment like radiofrequency ablation, which cost at least 50 to 60,000 minimum in any center. So we opted for transnasal sphenopalatine ganglion block in this patient. This is our study which we had done in our institute. Thanks to Department of Radiation Oncology and Medical Oncology for the support. So in which we have, in 150 patients, we have studied the effect of transnasal sphenopalatine block in head and neck cancer patients. And we found that morphine requirement has reduced in patients who are receiving sphenopalatine ganglion block. It has decreased from 90 to about 58. And the pain scores have also significantly improved. As you can see, immediately after the procedure, the pain dropped. And after 3 sittings, we get little consistent results after that. So what were the adverse effects? We don't have any serious adverse effect with this procedure. We don't even need to attach cannula to the patient. And epistaxis was reported by none of the patient. Few patients have reported nasal congestion, stuffiness of nose, that thoda bhara bhara sa lagta hai, and runny nose was there in 12 patients, but no major side effects. These are the standard PubMed indexed articles which are in line with our treatment protocols. This is an article saying that sphenopalatine ganglion block in management of cancer pain in head and neck cancer patients, and it is saying same thing, that they got approximately 80% relief, up to 80% relief in patients with average duration of 23 days. And this is another article of Indian Journal of Palliative Care showing that even home-based application of sphenopalatine ganglion block can be done for patients who are unable to come to hospital, are having malignancy, and caregivers can do this at home if they are trained properly. These are more indexed journals showing the same thing which we are doing. And there is also an article in which is showing that sphenopalatine ganglion block is very underutilized tool. Why underutilized? Because we are not using it. We started it about 3 years back. Dr. Seema ma'am guided us. And what happened, we are doing it now so frequently that every patient of head and neck cancer who comes to us, our residents are doing it independently, and we are getting good relief in those patients. Apart from it, other headaches like migraines are there. Patients suffer from acute attack of migraine. In that we can do this procedure and that attack can be terminated. These are our other references. So to summarize, he was a 65-year-old male of carcinoma of tonsil on chemotherapy and radiation therapy. So he was trying to manage on step ladder, but pain eventually applicated. So we resorted to interventional pain management. His pre-procedure and post-procedure NRS has drastically changed from 5 to 6 on morphine to 1 to 2 without morphine. And his psychosocial issues like his relation with his son and his fear of medication, his fear of cancer treatment has been handled very meticulously. Very long counseling sessions we had with this patient, and we tried to resolve them, restoring the faith of the patient in the treatment. So what is our take-home message from all of this? Pain is fifth vital sign. No matter in which department we are, medicine, ENT, neurology, psychiatry, we should always assess the pain. Pain is mandatory requirement for NABH also. Now it is fifth vital sign. And cancer pain, especially per se, is a very multi-dimensional, very complex and difficult to manage pain. Interventional pain management, not only this particular procedure, there are lots of other procedures which Madam enumerated earlier, like stellate ganglion blocks, celiac plexus blocks, superior hypogastric plexus blocks, intercostal nerve blocks. Multiple things are there. Ibuprofen, ketamine infusions. They reduce the need of oral analgesic medication and use of stronger opioids. Escalation to more stronger opioids, they are all reduced by them. And transnasal sphenopalatine ganglion per se, it's a very cheap, it is very less expensive procedure, very easy outgoing procedure with good outcomes, and nerve blocks are effective procedures for refractory and difficult pain. So I would like to thank Emeritus Chairperson Dr. Ahmed Sonkar sir, Dr. Vikas Sonkar sir, Dr. Sudhir Sajdev sir, Dr. G.N. Saxena sir for all the support since we are a new department, all the faith they had in us, all the support, infrastructure, equipment they provided us. Thank you sir, thanks a lot. And I would also like to thank Dr. Himmat Malhotra sir and all our patients who had been such a guiding force in our journey. Thank you. Sir, it is advised that 4 to 5 settings are required, especially for chronic pains. If we do 5 settings, then in studies it was found that its effect lasts for about 23 days on average, which I told as in PubMed index it was written. But yes sir, because we are using local anesthetic, so the relief is always transient. It will come back. If we want to go to a permanent measure, then we should always go for radiofrequency ablation of sphenopalatine ganglion block. That lasts for like 3 years, 4 years, or at least chemical neurolysis, which lasts for about 6 months to 1 year.
Is there a concept to remove this ganglion?
Sir, I think neurosurgeons might be more. I haven't heard of it, sir. I don't think, sir. It's a very complex area with complex anatomy. Maybe my ENT colleagues or my neurosurgery colleagues might be able to better highlight that, but I haven't read that about it.
So any scopy, laparoscopy or some scopy, like rhinoscopy. So
Sir, I am not familiar with that.
Is there any role of surgery, particularly when the patient has dysphagia, debulking the tumor?
Not in this stage. I just wanted to share a few thoughts of mine. Head and neck cancer is the commonest cancer. A large number of these patients go into advanced disease. Unfortunately, fortunately, whatever you want to call it, the termination is not very early. They suffer a lot, and we need to take care of the caregivers also. Because what is the most important thing where caregivers are put off? One is the foul smell, and two is the bleeding or anything of this. That is why they don't go to that. So we need to take care of the foul smell. This is an Indian problem. We need to find Indian solutions to this. Instead of giving gargles with Vitrogel or betadine or this thing, we need to integrate something with either the Ayurveda or somebody where they can find ordinary neem leaves or something like that. You can take care of the faults.
Sir, there is a mixture called Sudarshan mix, and we had prescribed it earlier in few of our patients. We have also told them, me and Seema members, that how to make it at home. They take metronidazole tablets, crush it, mint leaves were taken, and some povidone in very little amount, and even mint tablets were there. They were crushed and they were used for gargles. But what we found that it was difficult for patients to make that at home, and one or two times we have tried to prepare ourselves and hand it over to the patients. Yes. Yes.
Simple things like
it is very effective, sir. It is very effective.
That can be done for everybody. It's not another thing. We have requested the administration. Oral hygiene is very poor in these patients. Telling them to gargle is not good enough.
Yes.
We have requested that we have a dental chair in the OPD where these patients, all these patients can listen, because half the pain will be taken care of if the oral hygiene
is good.
It is better. And yeah, I think that's.
There's something that I don't have any statistical evidence of, but anecdotal evidence. Patients often come and tell us about the malignancy pains. The use of cannabis.
Yes.
That has, they say that it helps them. I don't know whether there are studies on it or not, but maybe it brings the threshold or something. Have you ever noticed?
Sir, cannabis actually is helpful, but not in the proportion it is marketed. Cannabis is actually... Yes, sir. If we compare it to the existing standard treatment, it is not that effective. But yes, it gives a feel-good factor also to the patient. So patient feels better when he takes cannabis. There are medically licensed cannabis products available now in India. They are slowly getting into the market, but they are not as effective as the standard treatment. It is seen in practice.
It's like it can be an adjunct.
It can be an adjunct.
You know, just to elaborate on what Dr. Rajgovind was saying, we have an in-house study on Ayurvedic preparation for oral mucositis, and Lalit is the PI for that. Very briefly, just give us an overview for that.
So this is basically we are using that babul ka chhal, acacia in the tree. So we are taking the chhal of that tree, उसको wash करते हैं, dry करते हैं, then उसका mixture बनाते हैं, and then we are boiling it 8 times of the water, and then once it is filtered and kept in the bottle. So we are about to start this study. Everything is done. So recruitment will be started to come next week. Initially we plan that we will be doing this study in 50 cases, and later on we will extend this. So this will be very cost-effective Indian solution. We all have tested, including Dr. Hemant Malhotra, sir, and we all. It is like tasty. The taste is okay. It is not bad. So we will be starting very soon.
Do we have time for a quick comment? There are many scientific associations and bodies that are providing funding for investigator-initiated studies, anywhere between 5 and 10 lakhs. And I'm sure that if there is a good project, you should submit.
Department of Palliative Medicine and I think
it is different, and for your expiratory abdomen it is different. Second advantage of going for a diagnostic block is that it tends to also tell you whether the pain has encephalized. Those who are having chronic pain, a huge majority of them, the pain might encephalize and therefore the treatment may not be effective. Right? Then one thing happens, what you have done is that you have gone for repeat blocks whenever needed. Now this is known that when you break the pain cycle, the benefit offered is much beyond the known pharmacological duration of the drug, local anesthetic in this case. Yes. And this I myself, I was doing pain work in my early career, knows it well. So this I had also mentioned, and I discussed it with one of my mentors, who is a very well known in pain medicine, Dr. Zimmerman from Germany. He was a famous pain physiologist, and in one of the conferences I asked him similar question because I used it for a trigeminal neuralgia patient repeatedly and prolonged and progressively increasing duration of pain relief. And he said that not only it gives you a relief, it might cause some mechanical changes in the nerve, some kind of maybe a sort of a damage which causes lasting pain relief. And when you go for chronic pain management, do go for a diagnostic block. Your approach may be physiological or anatomical.
For our program on Let's Talk About Death on the 16th of June. 15th of June. So final words of wisdom from our VC, Dr. Sudha, who is also a well-known anesthetist.